afternoon. Hopefully I won't get attacked by a penguin or anything, because we're near the penguins and flamingos here today. The board is, we're having a big retreat to talk about our global lens, as they call it, which is kind of our outcomes that we're measuring. So let me share my screen. Can you hear me okay? Because I've got you on the iPhone. So can somebody let me share my screen? Okay, we're good. Thank you. So let's do this and this. It even works at the zoo. What a deal. All right. My phone is a hotspot, so I think we're good. All right. So I'm going to give you a rapid, I've got probably more slides than I'll really cover in any detail, but we'll send the slide deck out about opiates and, in my words, medical in quotes, marijuana in 2021. Really in Ohio, I'm going to touch on that, but I'm going to show you some data from Summit County and from Cuyahoga County. So at least we've hit Northeast Ohio, where a lot of you are joining us from. So no disclosures, no one's paying me for this. I wanted to first just start with, I think, and a key point about all of this, which both of these issues is stigma, so that we don't forget that stigma around substance use disorders is even stronger than stigma against mental illness, in that it took until the height of the opiate epidemic for a Surgeon General, actually he's Surgeon General again now, I think, but at the time, November of 16, so in Summit County, Akron, we were the first in the country, sadly, to obtain, if you will, carfentanil, the elephant tranquilizer. In fact, appropriate for where I am at the zoo today, one of the first things we did was reach out to the zoo to see if it was stolen from the zoo, and it was not, because they don't actually have any big enough animals here at Akron Zoo to need carfentanil, which tells you the potency. So it took that level of pressure for the government, with our tax dollars, our federal tax dollars, to actually decide they darn well better talk about addiction, even though the stigma was still strong. So just to point that out, sort of historically, that is an historic moment. It took until, I won't make you guess, took until 1999 for a Surgeon General to do a report on mental illness. So you can see the distinction in still a lot of stigma, and of course, gradually it's getting better for both mental illness and substance use. But with that, we will move into the two main topics. So first, let me just tell you quickly, so you've seen it, and there's actually newer versions of this now, but the ORS report is one of the statewide initiatives, and of course, nationally, we can now connect to many, if not all states, with our ORS report, which is an automated prescription reporting system for controlled substances and any substances that we deem are being abused, if you will, using old terminology, but that of creating a substance use disorder. We've added those. So, for example, Neurontin it has been added because people were crushing it or are crushing it and snorting it. So they've added that to the report. And although I'll come to it again later, medical marijuana, because that is now recommended, although not prescribed, it still ends up on the report. So you can actually see if somebody is obtaining official recommended medical marijuana. So that is helpful as far as drug interactions and things that we're all learning, because that's new for us to be able to look that up in the database. So that's just another piece as we tie these two together around opiates and medical marijuana. And then we've learned through the course of the opiate epidemic a range of what needs to occur to be able to get people into care if and when we can help them get past the stigma. So acutely, people may need to come into a detoxification center. We actually have the largest in the state in Akron. And interestingly, during COVID, we have seen the numbers of people coming in, maybe fear of COVID, what have you, have dwindled greatly. In the beginning, we had 16 beds. We were full. There was at least a 7-day wait for periods of time. And we added beds and we added more beds. We got it up to 28 beds. And then since that time, we've had no wait. And then other places, many places around the state don't have a detox at all. So that is part of the continuum. So you can say to somebody, you want help, come in now. All right, no, not next Tuesday. Let's get you in here now to get help. The other end of the spectrum is residential treatment. And now there are, and many people have heard the phrase, the American Society of Addiction Medicine, ASAM criteria, where somebody gets evaluated and put into a bucket about, we believe this is the level of care a person needs, and that's how somebody might get placed into a residential type treatment program. In between all that are myriad outpatient programs that can be one-on-one with an individual counselor, one-on-one with individual prescriber, and then of course there are group programs and of all those natures. Within the prescribing, we now have pretty good use of medication-assisted treatment. MAT is how you'll see that written usually, and mostly historically it was methadone only. Methadone got a very bad stigma, quite frankly, because it hails back to the prior opiate epidemic, which was nothing by comparison to today's epidemic, but that was in the 60s and 70s, and methadone became this drug that only the people living in the gutter were using. But I mean, I can tell you, based on reports I've seen, there are Fortune 500 company CEOs today who have been on methadone for 30 years and is very productive. So that stigma doesn't even hold as far as a stereotype about who has taken it and who continues it. Unfortunately, many of those individuals don't share that. So you don't hear that from other people that look, I'm successful despite having had a substance use disorder. Along came two drugs, naltrexone as well as buprenorphine. And so these drugs came along, naltrexone is a true blocker. It came along for alcohol initially. Our Revia, R-E-V-I-A, was the original brand name. So naltrexone came along as an oral, usually 50 milligrams, and that is useful. But the idea here is to get somebody into longer term treatment. So now most people take this as Vivitrol if they choose it. These are all choices. No one forces these. So Vivitrol is a long-acting injectable, once a month antagonist. The plus is that many people say it gets rid of their cravings for the substance, the opiates or opioids. Let me make a comment there too. So opioid, think droid, like Star Wars, man-made. Opiate means naturally occurring from the opium poppy. We tend to use them interchangeably nowadays, even though I'll show you that opioids have become much more commonly the cause of death than opiates in the past several years. And then also along came buprenorphine, which is a partial agonist. Basically, that means it partially blocks and partially turns on the mu opiate receptors. And that means that the person often blocks the cravings. So the craving isn't preventing them from getting all the other aspects of care. Hence the idea of medication-assisted treatment. The medication is not curing somebody. It is helping to quell the cravings, the brain screaming at them that they need to go out and find or use or think about using, which is in effect the definition of addiction, all those three things taking up your time and energy. And you do that. Many people take it as Suboxone, brand name, because that is buprenorphine plus Narcan. It's formulated so that if you use it properly, the Narcan never gets engaged. But if you use it improperly, the Narcan will effectively block. It's another true antagonist, rather, and it blocks the receptor, and you go into withdrawal. So you actually get the opposite effect of what you were looking for. So in Summit County, where are we at? Because it's really today is more about where are we at. You've heard that. I just gave you that backdrop. So Summit County, we created the Opiate Task Force. It's now the Opiate and Addiction Task Force, because unfortunately there are many other substances that people use and lead to these use disorders, otherwise known as usually severe use disorder, now equates to the word addiction. So criminal justice, public awareness, youth and young adults, healthcare, policy and advocacy, and family support. We've had great activity in these, and again, other counties around the state have similar types of task forces. Ours is rather large in Summit County, something above 800 members at this point, of which probably 150 or 200 are extremely active by committing their time and energy to at least one of the subcommittees and then a quarterly meeting. And this is the true definition of it takes a village. So everyone's working mightily together. For example, on the advocacy side, we have the local legislators who come to the meetings, and we also have, at times, we've had the federal, their counterparts at the federal level come to the meetings, or at least their proxies that many of the federal ones have. Others who can do some travel on their behalf. And we've got a healthcare subcommittee, of course. So, for example, the head of our detox, Dr. Gary Thrasher, sits on that. I sit on that. Dr. Freebert sits on that. So many other people around the county sit on that to work on these things. And we choose based on who thinks they have the expertise. Of the 800 members, we have some individuals who are in their own recovery. We have some that are still struggling to maintain the recovery. We have family members of individuals, and we really need their voice in this. So just as one, where have we come? Where are we at in 2021? This is a big area that I think is very powerful. And I'll show you some data that proves that out. Here are some programs that have evolved out of the opiate epidemic. So Project Dawn, which is death avoided with naloxone or Narcan. I think it's horrible. We all live in a world of acronyms. Rarely do we have one where we have to have the word death in the acronym. So that tells you how serious this is. So deaths avoided with Narcan or naloxone. These are given out free all over the state through the Department of Health, and often funded by ADM boards, and including the Summit County ADM board. So you've got that in our public health department. I think they've even expanded access now to more days of the week. And you can even get these now when you go into a pharmacy and so forth. You can get them in through pharmacy connections as well. In fact, we just had a lecture in our CIT program last week for police, and Dr. Delos Reyes, who some of you know through the Opiate Echoes, she came down and gave our substance use mental illness lecture, as she's done now for 20 years. And she gave out Narcan kits. She has our grants. So there's a lot of money that's flowed for what's called harm reduction. That is, let's at least keep people alive. Let's not let them overdose, and let's gradually get them into care, ideally instantly, but not everyone chooses care right away. They're not in that stage of change, but we try to keep them alive until we get to that point. We have dump boxes. These have gotten tremendous use. I won't show you all that data, but we've had tons, literally, of pills only, forget the bottles, that have been gotten rid of by families across Summit County and across Ohio, that we all have faced it. Let's be honest. If you haven't already gone through your medicine cabinet to do this exercise, version of spring cleaning, I use myself. I was shocked at how many bottles I had that had 2 or 3 antibiotics left over from decades. Clearly, number one, not useful. Number two, who knows, possibly dangerous. And number three, certainly I know people who can prescribe me antibiotics. I don't need a backup plan. So that makes no sense. And so as an example, I didn't have any opiates in my cabinet because I've thankfully not needed them. But many people have opiates in their cabinets, and like for a rainy day. And our goal is get them out of people's cabinets, get new ones if you ever need them legitimately, so that your plumber, your neighbor's adolescent doesn't come over or whatever and visit and take them out of your medicine cabinets, because that is actually common. This is what a Dawn kit looks like, just so you've seen the newest version of these. So you've got the 2 nasal sprays. In the beginning, it was atomizers attached to a syringe, no needles. So they've really moved forward. Since this is a very medically oriented group here of all specialties, I want to mention this. So you'll notice the face shields in the foreground, clearly important. And I think this is one of those modern things I wanted to mention. You know, the timing was actually bad when they changed basic CPR and said, let's do compressions only and let's stop doing breaths. And the reason it was bad timing is that right around the time we started teaching that, along came people overdosing on opiates. Well, opiates tell your brain you don't need to breathe very much or at all, and you stop breathing. So when you find someone unresponsive, they need you to breathe. They don't need you to pump on their chest. If they've gotten to a point where you need to pump on their chest, they're probably not going to live. If it's because they had an opiate overdose and they stopped breathing 4 minutes ago, and then their heart stopped after that, probably a bad outcome. So the face shields are there to remind people that, and you can imagine how this played out in COVID. Please put the mask on their face and then breathe and get them breaths going. So just my thought about the where are we at? I think that still needs to be walked back. Actually, I suspect we've lost some people along the way for that. This is what if you don't want to take it to a dump box, those dump boxes tend to be in every police station. By the way, they don't ask any questions. You can tell your patients this, your loved ones, whatever. You walk in, you dump the bottles and everything into these dump boxes and leave. They don't care who you are. If anybody even notices, they'll give you a thumbs up. They're just happy you're getting rid of them. But not everyone's comfortable going to a police station. So we do, and of course, there are national take back days several times a year as well, where you can go and do that. But police are also there. So these Deterra bags, which also are often now given out, maybe somebody knows if it's always, but at least often given out if you're given a prescription of opiates or opioids. If you're given that prescription and you go in to get it, they'll also give you the bag in case you don't use them all up, as a symbol of please, when you're done and you don't need them anymore. They gave you 9 pills for your wisdom teeth removal. You only used 6 pills. Please throw out the other 3. And you literally put them in the bag. You take the top of the bag off, put the pills in, put a little water in there, seal it, shake it up. And even the Environmental Protection Agency says that's perfectly safe to throw in the trash at that point. So it's a very simple way. They have large bags that they've also created that you can get if you're, for example, you want to clean out your grandparents' cabinet for them. Maybe they're not going to do it, or maybe they're too infirmed to do it on their own, but you can go in and do that with a larger bag. So I want to be data driven. So here's an example of some data. Again, I'm starting with 16, which was our worst. You can see that Q3 right around Independence Day. So July 4th of 2016 is when carfentanil hit. And so you can see nicely a trend down, not perfect. Obviously, we still have 2+ showing up every day in the emergency departments around Summit County. It's only Summit County having overdosed and reversed with Narcan. So it's far from gone, but it is tremendously better than we were in 16, 17, 18, and even 19. Despite COVID, that part's gone very well. Here's an example of the overdose deaths by year. You can see here a wonderful downtrend from 16, 17 to 18. Unfortunately, in 19, we jumped back up, and all those factors are not clear at the moment, but a lot of it is that fentanyl became much more common as opposed to carfentanil. So fentanyl is an opioid. And in 2020, we were almost identical to 19. And actually, our 2021 data were very likely on target with 2019's data. We're going to be somewhere around that 216 kind of range. Again, is the way it's looking. Overdose deaths by month, again, just to give you a sense of how this fluctuates, although not that much in terms of over time. This is the rates of death per 100,000 population. You can see a definitive tendency for men greater than women to overdose, even when you do it by a per 100,000 population. So there's targets, obviously, towards males in particular in some of what we do. Here's by race. We've always broken it down by race, which has become more something people talk about in the recent couple of years. You can see here the negative. The negative is we've seen an increase in overdose death rates with African-American males that we had not seen previously. So we are currently targeting. So what are we doing in 2021? We are currently very much trying to work with our we are working with our faith-based communities to try to target this. Actually, this topic is part of our big meeting with our board of trustees today, as another example. Just a little bit more data about that breaks this down a little bit. Again, you can see the slides that, as I mentioned, so this comes from Dr. Kohler, Lisa Kohler, excellent forensic pathologist. She's our lead medical examiner here in the county, and she's a great team of other medical examiners. And you can see here that we've shifted in 21 to fentanyl being the biggest cause of death. There's overlap, and I'll show you a slide on that in a moment. Methamphetamine has come up in the ranks, unfortunately, as being in high enough concentrations that may have been the cause of death as well. And now cocaine is making its way back on the scene. Historically, cocaine, crack cocaine, more for individuals that didn't have much money. True cocaine for wealthier people who could afford the actual powder you see in the subject of movies and things of that nature. So here's the overlap. Just gives you a sense. You've got some people with a big mixture, some people with a couple of things in their system at a time. And you're talking, again, opiates, mostly synthetics, meaning opioids, really, methamphetamine, cocaine. So a lot of overlap with individuals with substance use disorders, such that, they're turning on at least dopamine, they may be turning on a lot of other neurochemistry as well. We do try to look in the modern world now in 2021, more than we did in 16. We're really heat mapping. Where are these people coming from? Where are the overdoses? So we can target. This is going on all over the state. A lot of places are doing this. We created quick response teams. This is a modern invention as well. We patterned this off of something that was occurring in Hamilton County, which is the Cincinnati region. And so we do this, and we go out to the individuals, usually a 3-person team, plain clothes, law enforcement, paramedic, and then either a peer support person, so a person with lived experience, or a counselor. ADM, we pay for the counselor or peer support when they go, and the other agencies donate their law enforcement and paramedic time as an in-kind gesture. And they go out within a week of anybody who's been reversed with Narcan and end up in the ER, because we have all that data. They go out to their homes, their residences, and say, we're here to help. There's hope. Let's get you into services. And so we track that, and we have found lots of people have gotten into care that probably would not have gotten into care. This is my favorite slide. I alluded to it earlier. I love showing this slide. So you can see once we added enough beds in detox, we've never had a wait since, really. People call, this is just as illustrative of people with substance use disorders and the ambivalence that many have about stopping entirely. What happened when we got to a point where there was no wait, you would have patients and or families calling and saying, I need to get into detox, I need to get into detox. We'd say, come right in. And they would say, I can't make it today. Can I come in Monday? Huge change. It definitely took probably 6 months for the community who was using the substance to adapt to the idea that if they called or they just showed up, they're going to get care right away. So that's interesting to me from a psychiatry point of view about some of those stages of change. Similarly, the residential used to take 60 days to get into residential. That's horrible. We created the addiction helpline. That greatly streamlined the process. And the mode of getting into outpatient care is 1 day. The mode is the most frequent answer. So if you agree to go to the agency that has an appointment tomorrow, we'll get you in there for care right away within a day. You may say, oh, no, I like that other third option you told me about because I've heard good things about that agency. I'll go in next Wednesday. So the average does get skewed more than 1 day. But so our residential mostly down there, the numbers actually now represent the wait. The several days will never be zero because it represents medical screening, other things before people go to residential. That's what fluctuates there, and that's been hard to change. Here's the effect. So I'm going full circle for Summit County. Here's the effect of the ORS report. The answer here is not zero, by the way. We don't want zero. Clearly, opiates and opioids are useful for pain when used wisely. You would not want to deny somebody with kidney stone pain some opiate if they needed it, or a bad injury or what have you. So no one's arguing to get rid of all of these, but we are looking for what's the right number. Recently, a board member asked, well, what's the right number? And of course, no one knows the answer. What is the right number of opiate or opioid doses dispensed per capita? I don't know the answer either. We do benchmark against the state and then Montgomery County, which is the Dayton area, simply because, but it gives you a little more of a statewide appearance as well, because they are similar in size and scope with their levy and their ADM board and so forth. So we tried to benchmark against somebody else, and that you can see that in general, Summit County has done better, we think, that we're not yet at the lowest number we should be at. So, but we're still below the state and in the Dayton area. And again, here's that demonstration of the ADM helpline and how much that's made such a difference. And I've got your statistical key at the bottom for mode, because most of us don't think about statistics that often. So, all right, real quickly, Cuyahoga County, thanks to Dr. Gilson for this. And you can see here, I've just got a couple of quicker snapshots for time's sake for them. But you can see they've had an increase in overdose deaths. We've not seen that here in Summit County, thankfully. On the other hand, we haven't seen a decrease, as I showed you. So we're better off than some parts of the state, but it varies a lot depending on population, what drugs are showing up in that part of the state, some of which is not in the control, of course, of the healthcare system. You can see they're giving out way more Project Dawn kits. Dr. Delos Reyes is up in Cuyahoga County, so she's clearly part of that, along with Metro Health. They have a wonderful opioid, I forget what they call, but response center, something like that at Metro Health. And their lead physician and her team do an amazing job of dealing with this issue. They've just recently opened up, so something else more modern, a MEC clinic, and I'm forgetting what it stands for. I apologize. I only heard it once, never saw it written down. But the basic gist is, if you're willing to come in and get your dose today, and we'll let you sit in a group, show up. If you can't show up tomorrow, we don't care. We'll see you the next day. And so it's really a low bar. Get people in to give them the help now, and let's keep it going. And of course, many of those people will end up staying and getting into higher levels of care if needed. But it's really is a goal to decrease the bar as far as getting people into care, which again gets back to stigma that I started this talk with. That we are, if there's anything good coming out of the opiate epidemic, it is that stigma is decreasing around substance use disorders, because by now everybody knows somebody who's been affected by the substance use disorder, if not in their family, then in their friend's family. It's really hard to find anybody who's not been touched in some fashion by this, just like nobody has had anybody not touched by COVID. It's really at that level of importance. So it just gives you a general sense. I won't go through all of this, but so you've seen it. They do a great dashboard there for Cuyahoga County, and you can see that down at the bottom here. There's a link you can click on and look through their data if you have an interest in that. Just to compare it to the Summit County, you can see here they've broken it down. They don't have their, interestingly, the methamphetamine on this one, but they do have the fentanyl, carfentanil, heroin, which you can combine, obviously, in the opiates, opioids category, and then cocaine, which for them is also showing up with some regularity in Cuyahoga County. Again, some heat maps just to give you a sense that everyone's looking at data the same way across the state. Part of that's driven by the Department of Health. In reality, a lot of the data from the emergency departments first goes to the State Department of Health, and then it gets fed back to the counties and our opiate teams. Again, just another snapshot here. Now you've seen, I wanted to hit more of the state. You'll see at the bottom right-hand corner, you get a sense of how much naloxone is being administered in the biggest counties. So you've got Summit in there, but you've also got Franklin, one of our viewers today. I heard you're in Franklin County. That's wonderful. Thanks for joining. In other counties, you get a sense of kind of how this is playing out, getting the naloxone out there, and then how much is EMS having to respond and use it to reverse, hopefully effectively, an overdose, near death, and get them into the emergency department. This is how that data gets fed back. Prescribing, again, you can see a general sense here about the prescriptions. You'll notice gabapentin, which is what I mentioned at the beginning, is on there because that has been a drug of misuse, I guess now we say instead of abuse, but a drug of misuse as well. Another big problem. Again, I won't go through all this, but it just gives you a sense of all this with suspected overdoses. What are the age groups? Where is it happening? You can see most of it's smack dab in the middle of our probably most productive part of our lives, from 25, from 25 to 49, then into your 60s and so forth. Okay. I guess since I'm talking from here, I'll take questions at the end. So here's medical. I'm going to shift gears quickly to medical marijuana. This will be quicker than the other part, just to give you a sense. So this website is the medicalmarijuana.ohio.gov. I'm going to show you the physician and the patient side of this, but everything's on this one site, which is actually great because you can learn anything you wanted to about either how to become trained to be able to recommend. Again, we do not prescribe medical marijuana. You can recommend it. And you can also get in there about abuse prevention, other resources. So it's actually a very robust website. If you are a patient, you can find who are the people recommending it in your area. And I've watched that for the Summit County area, and I report that actually back to our board of trustees several times a year, just so they have a sense of how that's changing. I can tell you that across the state, none of the big, and I think literally is none of the big healthcare organizations are accepting medical marijuana as useful. So Cleveland Clinic, Metro Health, Summa, etc., are not. Nobody there is recommending medical marijuana. So just be aware that that tells you something. I believe that's true for the hospitals in Columbus, etc. So they're just not. The science isn't there, and because of that, there are frequent attempts to add new diagnoses that would allow a prescriber. I'm sorry, would allow a physician to recommend medical marijuana. They keep trying to add more in the psychiatry arena. They have not been successful. Most recently, anxiety and depression. They've attempted to do that. You can see here what is allowed. This is the most current list. You'll notice I highlighted in green the only two things that even touch on mental illness or even substance use for that matter are PTSD and Tourette's. So it's really not something that we use in the mental health or substance use arena. It would probably be counterintuitive to use medical marijuana for substance use disorder treatment anyway. But someone's going to try. I'm sure they're going to. So this goes up to the board, and they have to go through it and decide what's real, what's not real. Sadly, there's actually almost no evidence for any of these uses for this. There probably is value in pain. And that, of course, if we can treat pain differently, maybe we avoid opiate epidemic entirely if we'd had some better approach. The positive also that's come out of all of these changes with marijuana is research. So we would restricted the research even by categorizing it as a Schedule 1. Now we're at least allowing research to occur. So we're learning more about THC, more about CBD, the two components in this. And you've heard other talks from experts like Dr. Messamore and stuff about that topic previously. Just to show you, you can click on the whole state. You can click on your area. So here's Summit County. This is on the website as well. And it shows you, I won't make you count it, 17 recommenders exist right now in all of Summit County. They're all basically individual practices, physicians working on their own, not for any of the big systems, which of course is a rate limiting factor since many practices are agreeing nowadays to get bought up by the bigger systems to avoid all the headache functions of financing and hiring and firing and all that, and that allows the physicians in particular, but certainly all the other practitioners, to do what they do best and not try to deal with all the business side. So here's a broader one. I wanted to also do Cuyahoga since we're looking at this statewide. A larger array of people. Again, you'll notice none of them really are in downtown Cleveland where the big hospitals are. Right. So that gives you just a picture that to match what I'm mentioning here. And then finally, the Recovery Ohio website is relatively new in the recent few years, does have quick access to other information for both providers and patients and families. I just point that out. You can see what else has come along in recent times for getting care. And I know you're all wishing for this at this point, and I will take questions. This